To welcome and hear about Emily Dworkin's research today. She is a licensed clinical psychologist as well as an acting assistant professor at the University of Washington School of Medicine. And she's done some great research on trauma-related psychopathology and specifically with sexual assault survivors. And we're going to hear about some of that today. So thanks for joining us, Emily.
Yeah, thank you, Brooks. I'm really excited to present here. I feel like this is a group of people that think in ways similar to I think. And I think that this project in particular will be one, hopefully that's up your alley. And this is something that Joe and I have been working on. I see he's on the call. So Joe, feel free to chime in at any point.
Thanks.
All right, so just to get started, as I'm sure I don't have to convince you, one of the things that motivates my work is the concept of the harm of sexual assault as a public health priority. So I have a community psychology background. I worked as a rape crisis medical advocate for 10 years. I really think about this as sort of not just a individual level problem that individual people suffer with, but something that affects us on a public health level. And even, people may not be directly affected, but everybody knows somebody in their lives that's been affected by sexual assault. And this is evidenced in part by the high prevalence of sexual assault as a form of trauma, which is part of why I focus on it specifically. So we know that about 1/5 of women in their lifetime will be sexually assaulted from epi data, about 2% of men. And the data are not great for trans and non-binary individuals in terms of not being high quality data yet, but we know that about 1/3 of transgender individuals will be sexually assaulted in their lifetime. The other piece that motivates me in terms of thinking about this as a public health problem is that PTSD is more common after sexual assault than other forms of trauma. So the risk for PTSD associated with sexual assault is about 19%. This is compared to about 4% associated with any trauma in general. So as you can see, it's a much higher risk for PTSD following sexual assault. And I'm sure this is telling you something again that you already know, but what we think about with PTSD, post-traumatic stress, is that it's a disorder not of the presence of symptoms, but of the failure of those symptoms to recover naturally over time. So post-traumatic stress symptoms are typical right after a sexual assault. I should say these are data from a meta-analysis of prospective studies from the time of assault that just got another R&R, so hopefully it'll be coming out soon. But about 3/4 of sexual assault survivors meet PTSD criteria 1 month post-assault. And then following that point in time, what we see is this period of rapid decrease in symptom severity. So at about 3 months post-assault, only about half of survivors meet PTSD criteria. And I say only about half because that's a decrease from 3/4, but that's still a substantial number of survivors that by that point have had significant symptoms for 3 months. And then we see a bit of a leveling off in the rate of recovery, such that by 12 months post-assault, about 41% of survivors meet PTSD criteria. So this means that even though there's this period of natural recovery, there are many, many sexual assault survivors who are going to be experiencing chronic symptoms over long periods of time. And we know that treatment works for this psychopathology, but unfortunately, there's some problems with that. So only about 1/3 of people with PTSD ever receive treatment for it. And then only about 7% start getting treatment in the first year after disorder onset. So even when people are getting treatment, they're still suffering from the effects of trauma for long periods of time. And indeed, the median duration of delay to treatment seeking is over a decade. So really, this is something that is a high burden of illness for long periods of time for many people. And these chronic symptoms have significant psychosocial costs for survivors. So I talk about PTSD because it's a common disorder following sexual assault, but it's by no means the only problem that is present in sexual assault survivors' lives as a result of the assault or as a secondary result of experiencing the symptoms. So people experience disruptions to their relationships or loss of relationships. They have more difficulty being effective in their relationships, in work environments, in school environments. It becomes harder to meet their goals for themselves. And so I think that that goes to show that it's really important not to just think about this as, what are we going to do for survivors one-on-one when they show up in our office, but what can we do on this public health level to reduce the disease burden of PTSD following sexual assault? So to do that, one of the things I think about, if we're going to reduce the disease burden, part of it is that we need to reduce the amount of time that people are ill. And to accomplish that, I think we need to think about how natural recovery works, how that period of rapid decrease in symptoms works, to see if there's something we can do to leverage that to make it even stronger or happen even more quickly. So the way that I think about natural recovery working based on evidence-based models of this is that trauma survivors experience reminders of the trauma, so assault-related thoughts, memories, emotions, external reminders. These reminders then elicit a set of symptoms, including cognitive, emotional symptoms, and kind of re-experiencing or being keyed up or on edge. And as a result of that, the most understandable thing in the world to do, and what probably I would do if I was experiencing these symptoms, would be to avoid the reminders. The problem, or the thing is that the thing that helps natural recovery is non-avoidance of those symptoms. So that non-avoidance of the symptoms and the reminders allows emotional processing and natural recovery to occur so that the symptoms become less intense over time. It's sort of breaking the link between the reminders and the symptoms associated with them. And then the problem, though, is that when survivors avoid these reminders and symptoms, that can get in the way of these natural recovery processes. So I don't say this to say that people are causing their own disease burden. What I mean to say is that people are dealing, we're sort of asking them to deal on their own with these really distressing symptoms, and they're responding with the tools they have available to them, which is to avoid the symptoms, which unfortunately has the long-term effect of maintaining the symptoms over time, even though it works in the short term. So how can we leverage this knowledge to promote sexual assault survivors' recovery? So basically, the thing that I think about is that, we have all these tools to help trauma survivors that work really well. And these tools are not rocket science. If they were rocket science, we wouldn't be able to teach them to people in 12 sessions of cognitive behavioral therapy. They're not complicated concepts. So if we get in there early and teach them these skills in kind of a distilled version, we might actually be able to promote natural recovery. So I think about this almost sort of as an inoculation against symptom chronicity. So one option here might be that it speeds up recovery so that the kind of initial slope is steeper, even though they kind of end up at the same place. So the people that would have chronic symptoms are still always going to have chronic symptoms, but the people that aren't going to have chronic symptoms spend less time experiencing the negative effects of those symptoms. Ideally, though, we would also increase the number of people who recover. So not just speeding up natural recovery, but enhancing recovery processes for all survivors, including the people that would otherwise have chronic symptoms. And we know that early brief emotional processing interventions work well for sexual assault survivors. So I was involved in an R34 done here at UW of basically one session of cognitive processing therapy, one 90-minute session plus a few 15-minute coaching calls to help people apply cognitive restructuring over just a few weeks. And the data have not been released yet, but the effects on PTSD symptoms are completely striking. Like whenever the study assessors would report on outcomes, it was like the people that got that intervention did not have symptoms, and the people that didn't get the intervention still had the same symptoms at the beginning. Like it was just such a striking effect. And that's consistent with other early brief, prolonged exposure type interventions. There's a number of these interventions that have been tested, and their effects are somewhat moderate for trauma generally, but for sexual assault specifically, probably because you have more room to improve because symptoms are so much more substantial right after sexual assault. They seem to work really well. So Barbara Rothbaum's 2012 study of a brief prolonged exposure intervention, it had significant effects overall, but when they looked by trauma type, there were only significant effects for the sexual assault survivors and not other types of trauma. So that goes to show that there's a lot of potential here to get in early and to inoculate people against these sort of long-term coping strategies that might get in the way of their recovery. But when I think about these interventions, I think about this, like I said, from a public health standpoint, where we consider impact to be a function of reach times efficacy. And I cannot, for the life of me, I did not make this up. I cannot remember where I got this from. I feel like I saw Joe say this like 5 years ago before we even worked together. So I'm going to give you credit for this, Joe, maybe apocryphally, but we need to think about, if our interventions are going to have an impact, they need to be reaching a large number of people and they need to be efficacious. But you can have something that's maybe a little bit lower efficacy that still has a major public health impact because its reach is really large. The problem is that our interventions that we, speaking on behalf of clinical psychologists, are developing are very efficacious, but their reach really stinks. So it kind of, we can really help people, but we're containing these skills to a small number of usually PhD level psychologists that need to go through intensive training, need to buy a manual, need clients to be showing up, willing to do this, willing to stay engaged, able to understand worksheets that are often written in like a college level reading level by other PhD psychologists. There's just a lot of things working against the reach of these interventions, as I'm sure I don't have to tell you all. And I think part of the issue here is that the professionalization of these support skills in particular limits reach. So I think that one of, the value I have as a clinical psychologist, maybe, because I consider myself to be a secret community psychologist infiltrating clinical psychology, is that we have this approach that you need to have a lot of expertise and training to do these things well. And whether or not that's true, basically, if we design interventions with that in mind, we're really going to be limiting, we're going to have a ceiling on the reach. We're going to have a ceiling on the number of people they can access. Because even if every person in the country who needed therapy wanted it, there would not be enough of us to be able to do that. So, I think that we need to, instead of thinking about how can we do our therapy better, think about how we can put ourselves out of a job, how we can stop being the ones that are providing these treatments and find other ways to get these pretty simple concepts to people where they are. So I think about this as getting psychology off the couch. So, instead of us being the ones to do things, who can we transfer that task to, whether it be non-specialty providers or, in my dreams, people in trauma survivors' lives. You should be able to go to your friends and family, and they should be able to facilitate your ability to use effective coping strategies rather than get in the way of your ability to do that, or discourage you from doing that, or encourage coping skills that aren't effective that you might not have otherwise thought about. The other thing that I think about is that psychotherapy asks a lot of people in acute crisis. And I say this, as a big fan of evidence-based psychotherapy because I do it and I see it work for people. And it is maybe the most magical thing I get to do in my work, to see somebody come in with PTSD and leave without PTSD. But it is, even 12 sessions of therapy is a lot, especially when you are immediately in the aftermath of a trauma. These therapies ask people to do homework daily, which I agree is important and valuable, but it is a big ask for somebody that's just experienced a trauma, if we're thinking about this in the early intervention context. So, this brings me to the idea that we might need to think beyond trauma survivors and think to look to the context surrounding them. Nearly all survivors of sexual assault disclose the assault to others, and in particular, most disclose the assault to family, friends, or romantic partners. Those who disclose to more formal services like therapists or the medical service system or the police usually have disclosed to somebody in their life first, which means that these emotional processes don't happen in a vacuum. They're happening in these conversations with other people, which ideally are leading those symptoms to reduce over time. But the problem is that people in survivors' lives, like I said, often get in the way of emotional processing. So they may encourage survivors to avoid reminders of the trauma, saying things like, let's get your mind off this, like, how can I distract you? Taking them out for a drink to kind of chill them out. Or they might do kind of more actively, intentionally harmful things, like blaming them as a little judge there, if you're not sure what that guy is. Being judgmental, asking a lot of questions that imply that the survivor should have done something different to prevent the assault from happening, which can then get in the way of this natural recovery process. And the problem is that these reactions are not uncommon. So 89% of survivors receive at least one of these negative reactions. And in a meta-analysis that I did in part using a lot an data provided by Heather, looking at association. I think we have an audio on. I don't know if whoever's in the meeting is able to mute that. Okay, so basically what we found in this meta-analysis is that these negative reactions are associated with down the road increases in symptom severity. So positive reactions didn't seem to make much of a difference in longer term symptom severity, but when survivors got negative reactions, months and sometimes even up to a year later, they had more severe symptoms of psychopathology. So I think about these social contexts around trauma recovery as kind of the water in which survivors swim. And if we came across a lake where there were sick or dead fish, we wouldn't ask ourselves what's wrong with the fish or what they're doing to not cope well, right? We would ask ourselves what's wrong with the water. And so I think it's incumbent upon us as psychologists and as people that have skills in making change in people and contexts to look towards those contexts rather than just looking only at the trauma survivors and trying to make change just for them. So, I think, this brings me to this idea that there's an unmet need to improve survivors' social contexts. This is not something that's typically the site of intervention for us as psychologists, with some notable exceptions. I think about Candace Monson, for example. Andrew and I met yesterday to talk about some of his work in this area as well. But really, there's very little done to change the context around survivors rather than just changing survivors. And the context around survivors, say that they need and want help. So supporters of sexual assault survivors often don't know what to do. More than 2/3 of supporters say that they're unsure how to help survivors in their life. And 3/4 experience at least some difficulty in helping the survivor in their life. So if we were to train these supporters, if they were to be the people getting the inoculation rather than survivors, that would put the intervention and the locus of intervention in survivors' natural environment. So it would be kind of meeting them where they are to deliver something that might be effective in preventing chronic symptoms. So instead of just being kind of a one-time dose, then if you make change in their context, you don't have to just show up once. You're giving them something that's then present over time. So, even if they stop doing their homework, or even if they forget everything that they learned, the people around them, to the extent that they remember what they've learned and they're convinced about how to help somebody recover from a trauma, they are able to keep giving booster doses basically of this inoculation over time. And there are many natural opportunities to intervene with survivors. So I said I started out as a rape crisis medical advocate. So I'd go with survivors to the hospital when they got sexual assault forensic exams, which are commonly called rape kits. And I would sit with people in the waiting room and sit with their families and friends and sit with them while they were actually getting the rape kit. And the vast majority of survivors had some support person there. And it really struck me just seeing how they interacted with each other, how powerful those support people could be. And that was kind of the impetus of some of this thinking for me initially. And then when I was on internship in Mississippi, I happened to come across the RCT of this intervention that I'm going to talk about a bit later. And I was so excited to see that somebody out there was sort of thinking about the same thing already. So, there's also, because I work really closely with advocates still and with sexual assault nurse examiners who do these rape kits, there is a just really strong interest and demand for something that they can give to survivors' family and friends. And in fact, the DOJ's national protocol for doing these exams say that that advocates and nurses should be providing support and information to victims' families and friends, but there right now is nothing in existence that has been tested or that is standardized or that is based on the best available data. It's sort of kind of made up ad hoc by different localities. So I think that really presents this unmet need that there could be a lot of room for growth around. And then when we talk to supporters and survivors about this, we hear from them too that they want supporter-focused services. So I did just a waiting room questionnaire at my local level 1 trauma center who collaborated with me on this grant I'm going to tell you about. And so I gave questionnaires to every survivor and supporter showing up for follow-up visits. It's a medical and social work visit following the rape kit. And every single supporter we gave this questionnaire to said that they would have agreed to be trained in providing support had we offered it to them. 81% of survivors said that they would have wanted that person who was there with them to be trained. This was pre-COVID, so we were anticipating just doing it with whoever showed up. And so we wanted to get a sense of whether that person would have been the right person for survivors. But I expect that if survivors are able to have greater flexibility in choosing who gets trained, more survivors would say that they wanted this. So that brings me to the intervention that has been so exciting and inspiring to me, which is called Promotion of Emotional Disclosure, which Joe Ruzek and Matt Cordova created, I think about 20 years ago, as I've learned recently as part of Matt's internship project. And basically how POED works is that when people are admitted to the hospital for a illness or injury, they get a 60-minute dyadic psychoeducational appointment, I think within the 2 weeks after the hospital admission. And then they get 2 weeks of time to kind of practice the psychoed skills, which I'll go over in a second, on their own. And then they come back for a 60-minute dyadic review of what they learned and how things went, and kind of some time to troubleshoot things. The content of POED, kind of anybody who does CBT interventions for PTSD will be very familiar with the common reactions of psychoed. So kind of normalizing and validating what they're experiencing, the symptoms they're experiencing as a reaction to their illness or injury. Then it goes over psychoed about disclosure and emotional processing. So it emphasizes the importance of bi-directional disclosure and processing between the traumatized person and their supporter. It discusses what are referred to as social constraints on disclosure and emotional processing. So these would be reactions by the support person that get in the way of the survivor's ability to process their emotions and share openly. So this is a subset of what we in the sexual assault literature called social reactions, and these would be the specific kinds that involve kind of distraction or kind of encouraging avoidance or kind of getting them to stop thinking or talking about it. Then they go over some do's and don'ts for both the trauma survivor and the supporter in communicating openly about feelings. And then there is a motivational interview, kind of a MI light to increase the chances that they're gonna actually talk about their feelings following the session. And then it goes over do's and don'ts in coping, which is sort of a giving some positive activities that they can do and discouraging avoidance-based coping. What you will notice in this is that there is not, there's not disclosure of trauma or trauma-related emotions in the actual session. It's really just sort of a psychoeducational session. It is meant to be delivered by non-specialty providers as part of standard services. So I think in the trial, it was provided by nurses and social workers primarily, definitely not PhD level psychologists. And in the RCT, they found that POED was effective for these non-interpersonal forms of trauma. So when you look 2 years later, the people that were randomized to get POED, 42% of them had received negative reactions from people in their lives versus 3/4 of the people in the control group. So people that participated were less likely to get negative reactions. Maybe the more striking finding is that nobody who got the intervention met PTSD criteria at 2 years post-trauma, compared to about 1/4 of the people in the control group. So, you know, when I saw this, it just floored me. I have not seen effects this strong for other early interventions. And this is much shorter, much more disseminatable. Just, you know, and gets to the sort of context around trauma recovery that a lot of others don't. So, you know, if these held up to replication, that might mean that intervening in context might be kind of one of the parts that we're missing from a lot of other early interventions. And then I just was kind of struck when I was making these slides to see the graph in the RCT looks almost exactly like the graph of the kind of what we would hope to see for the best possible outcomes for an early intervention to promote natural recovery. So when I was looking at this, what my initial reaction was that, you know, this is not focused on interpersonal trauma, but it might be even more helpful after sexual assault, given just how fundamentally interpersonal sexual assault is and how powerful social reactions can be to recovery, as I discussed. So that led me to reach out to Joe, must have been like 3 or 4 years ago, to start having some conversations that ultimately led to this project. Just sort of about my desire to adapt this for sexual assault, and talking about, you know, where are we going to find funding and what would this look like. And I last March, in the first days of lockdown, submitted a grant to the Department of Justice to adapt this for sexual assault and test it in a pilot trial, which I then was convinced that they had lost, and because I didn't hear anything back. And then all of a sudden, one day in October, got an email congratulating me on my new grant. I was like, that's funny, because I, you know, didn't know I had a new grant. And so we have been working since then on putting this in, or getting this off the ground. Or I should say, my fabulous collaborator, Sky Fitzpatrick, came up with the world's best acronym, which is Communication and Recovery Enhancement. And we made this logo for CARE, the new intervention. And then I realized that I was maybe the most naive person on the planet, because I was like, well, this is going to be easy, you know. It's just a dyadic intervention to reduce social constraints, promote processing. I can probably just like search replace trauma with sexual assault, and that would probably be enough, right? As if I had never learned anything from doing any of this research. So when we got down to brass tacks about this, it ended up the content, so it's almost a total rewrite, but most of the content is similar, just sort of reshaped. So the original content includes common reactions to illness and injury. That was a pretty straightforward change, just common reactions to sexual assault. The first inkling that I had about my naivete was when we got to the importance of bidirectional disclosure and processing. So the trauma survivor is talking about their feelings about, you know, the car accident, and then the supporter is saying, this is how I feel about the car accident. And that just felt really fraught for sexual assault. And that maybe it wouldn't be so appropriate for the supporter to be sharing how they felt about the assault having happened. And that could really open things up to maybe some negative reactions. So the reframing here is that the important thing is that the survivor be a person to whom the survivor can turn when they want to talk. So not forcing the survivor to talk, but kind of opening the door for the survivor to know the door is open and choose to walk through when they're ready, rather than kind of emphasizing the bidirectional nature of this. POED focused on social constraints on processing, and we really expanded that in CARE to focus on the importance of just generally avoiding, in part via talking to others. And I think I left this off this slide, but it comes up here where we shift the do's and don'ts in communicating about feelings, which previously was about starting the conversation and social reactions and giving feedback, to going over how survivors versus supporters can kind of open the door to the conversation. And then a really in-depth review of various negative social reactions and kind of why supporters might provide these reactions and examples of this and kind of what to do if that starts coming up. And then offering active supportive listening as an alternative to those reactions. When you don't know what to do, default to that. And then it addresses what to do when your needs don't get met. Either the survivor's support needs aren't getting met, or the supporter, you know, still wants support from the survivor and isn't sure whether it's okay to go to them, kind of what to do in that situation. And then we changed the motivational interview to more kind of an ongoing discussion about the pros and cons of talking versus not talking. So still kind of MI inspired, but a little bit less formal and more kind of woven in throughout the session. And then we had a lot of conversation, Matt, Joe, and I, about what to include with regard to the do's and don'ts of coping. And, you know, we're like, we have them, so we really want to give them something around this, but also this intervention is supposed to mostly be about dyadic communication. And so, you know, is this really about dyadic communication? So we brought it back to this concept of how it's important to avoid avoiding, and that there are two ways to do this. And one is to talking to supportive people in your life, and the other is keeping a healthy routine. And it goes over some examples of things that they can do to keep a healthy routine. Okay, so that is kind of the quick and dirty overview of CARE and its foundation. So, you know, as we've been talking about how to structure this intervention, the trial, a big part of our conversations, again, has been increasing the reach element of this, because the whole point of this intervention is that it's something that should be able to get in a large number of people's hands, because it's simple. It is something that can be provided by non-specialty providers. It can be, you know, in survivors' contexts rather than just to survivors. So what can we do? What should we be thinking about from the very beginning to increase reach? And this brought me to this sort of user-centered design approach. I have a K99R00 award to design and then test early intervention app that I'm not going to be talking about today. But as part of that, I learned this user-centered design approach from kind of the technology world that I really have been excited about in the mental health services world. And I am definitely not the first person to have this idea. And in fact, there's a lot of really amazing people at UW doing this work. But I thought about, how can we bring this kind of approach from the very beginning of adapting this intervention to make it something that has broader reach? So the kind of goals of a user-centered design approach are to make something that's easily learnable so that people can really learn and understand the concepts of the intervention. Something that's efficient, so it conveys the intervention it needs to convey quickly and without too much trouble. It's something that's memorable, so it's something that people will remember over time, and it's not like 1,000 concepts that people will just sort of lose sight of as soon as they leave your office. It's something that reduces error, both in terms of, and I should say all these are in terms of the user as the provider, but also the user as the client. So it reduces the degree to which providers or clients kind of make errors in how they're applying the intervention, and catches errors and addresses them as they happen. Something that maximizes user satisfaction in the intervention. So it's something that they like to do. Doesn't require a ton of cognitive load, kind of just straightforwardly presents things to people, and exploits natural constraints, which I really like as a value of this. But instead of seeing kind of constraints in the environment as a limitation, thinks about ways that it can kind of harness those constraints to enhance the intervention. So, and as I just sort of briefly mentioned, when we think about user-centered design, in this case, we have 3 users, which is the survivor, the supporter, and the provider. So we're thinking about how do we maximize those elements for each of these 3 types of users. So the first thing we did, and this was in part a function of the fact that submitted a very different grant in March 2020 than we're going to end up doing. But we're going to be delivering this via telehealth. And so I made a slide deck of the concepts, or the psycho-ed that you teach in the intervention. And this increases reach just because people don't have to show up at my level 1 trauma center to be able to do it. But it also has some other benefits, which is that it reduces the errors in delivering the intervention, so it can really standardize it across providers. It lowers the cognitive burden to really simplify it and just present 1 slide at a time. The provider isn't having to track 2 people plus what they're teaching. It's all just sort of laid out right there. And I think that this is a good example of exploiting this natural constraint of a pandemic, or about that it's hard to reach people one-on-one. And in fact, it's not just something we're kind of doing just because of the pandemic, but it's something that is actually enhancing potentially the delivery of this intervention. And I actually would like to see the slides used even if people are doing in-person sessions. They can just pull them up on their computer and really simplify the delivery. We also, I made these sort of simple summary materials of everything they learn in the intervention. In case you have not noticed by my slides, I really dislike text on things. This still feels like too much text to me, but I'm sitting with my distress about it. But we really tried to simplify it as much as possible so that people weren't having to kind of track a ton of things over time and be overwhelmed by the amount of information they were given, which then hopefully increases people's ability to learn the content and then remember it over time. And then, initially when I thought about this intervention, when I was an advocate, what I was imagining was something that could be provided just to support people. Because when I was with people in the hospital, the survivor would go into the exam room to get the rape kit, and the supporter would be waiting in the waiting room, sometimes for 3 hours, like sometimes for a really long time. And it was sort of a captive audience, and they were just sort of twiddling their thumbs. This was also pre smartphones that I was doing this. So people were really bored and just sitting there. And I was like, I just wish that I had something to give them, and I didn't have something to give them. And so if we made a version of care that could be delivered just to supporters, then that could be really directly implemented in these survivor serving settings, like hospitals or kind of concurrent to survivors therapy sessions, or other, maybe even police interviews. Like there's a lot of things that survivors have to do alone that they bring supporters to. And so we set up the manual so that it can be delivered either to the dyad or just the supporter. And we're going to randomize people to one or the other in the trial. But I think the ideal situation long-term would be that the survivor chooses which one they want. And ideally, the supporter's only getting it if the survivor has consented to that, because not doing that is sort of like talking about somebody when they're not there, which could be a little bit uncomfortable for somebody that's recently been traumatized. So hopefully this makes it more efficient because it's maximizing, it's using kind of the time that survivors are there to do these concurrent appointments. Hopefully it increases satisfaction, because from our pilot data, our pilot waiting room questionnaire, people were saying that this is what they wanted. And then again, this is exploiting the natural constraint of, not having access to the survivor while they're at their other appointment. And then another thing we're doing in this trial is ensuring the changes reflect survivor and supporter needs. So we're going to enroll 8 to 10 dyads who are going to review the content, both the dyadic and the supporter only content, although they're almost identical except for kind of the probes about the content. And we're going to ask for feedback in sort of a classic user-centered design testing session, and improve the intervention based on that, which hopefully is going to be something that increases user satisfaction. And then another big thing that we've been doing in this is reflecting on the risk of Eurocentrism in developing these interventions. So I'm sure that I don't have to tell you that academia and generally in psychology specifically has a lot of disparities in kind of who's represented and who's making the interventions and who's being recruited for trials. And so one of the things I've really been thinking more about is that the success of our interventions and our trials really rises and falls on the degree to which we're making it relevant to people across dimensions of identity. And I think that the kind of common move is, we're doing a lot of things, we're moving really fast, we're working with the people that we have ready access to. And so we end up having kind of all white teams developing these interventions, developing the studies, reviewing the content, making these day-to-day decisions about the study, and assuming that that will be good enough, and assuming that we, because we value diversity and inclusion and equity, that our value of that will help us catch all the things that we need to catch. And I just really have become more and more convinced as I do more work on this that is just fundamentally insufficient. And I have made a couple kind of commitments to myself in moving forward with my work. And one of them is that I am no longer going to have all white teams in any capacity. I'm not going to submit grants with all white co-investigators. And not in terms of like, I think that could get easily into kind of a tokenism type thing, but really just how evident it's been in every single meeting and interaction I've had with people about this topic, how much, even with the best of intentions, you miss when you don't have people at the table with lived experience of inhabiting these identity groups. So part of this is that I hired 4 consultants with expertise in culturally specific adaptations of CBT interventions, most of whom work specifically with CBTs for PTSD, to review the intervention materials and content and provide feedback kind of at this early stage of adapting the intervention. And we're still in the process of doing that. Natalia is also part of our core UW study team, which is 50% Spanish speaking, and just, you know, two-thirds of the Spanish speaking members of the team are native Spanish speakers from not from the United States. And in every single meeting, they bring up something that I would have missed about even just like the recruitment materials or how this question is asked. And I just have been so thoroughly convinced, just imagining how this trial would have gone if I hadn't included them, that I'm never not including people of color in my study teams again. So kind of leading into this, what part of what we're doing is increasing the availability of this intervention to monolingual Spanish speakers. So we budgeted for translation of the materials and measures. We were going to use an in-session interpreter, which we went back and forth on, but because this would be likely how it's done in practice in a healthcare setting, we wanted to make that as realistic as possible. And then I prioritized hiring a Spanish-speaking clinician, who's also the research study coordinator, to be interfacing with participants. And then 2 of our 4 consultants have expertise in Latinx cultural considerations. So they're reviewing the materials with that in mind. I will say though, you know, we're going to these great lengths to make it more inclusive. And just last week, I was meeting with the Level 1 Trauma Center folks about recruitment for the usability testing sessions. And I showed them the English language version of this flyer. And the providers of color in the meeting were like, this is the whitest thing I've ever read. They're like, you know, this is white and sterile, and I wouldn't want to do this if I was a client. And I just can't envision this being something that sounds friendly. And I know you put a person of color on this flyer, but that is not good enough. And I was so glad that they told me that. But I think it even goes to show just how essential it is that white people aren't the only people making decisions at each even minor step of the way in this process, even as something as simple as looking at a recruitment flyer, which had been, you know, reviewed by our study team, which, like I said, is not just white, but still kind of the perspective of non-academics who are people of color was missed in that. So hopefully this, I mean, I think there's a lot of reasons to reflect on Eurocentrism, but hopefully a big part of this is that it increases people's satisfaction with the intervention and the degree to which it's relevant to people's lived experiences with recovering from trauma. We also developed a provider training, which we did at the beginning of the month. And I made a slide deck for that too, to make it more disseminatable, which should increase learnability, hopefully, for providers. So just briefly, and I want to save a little bit of time for Q&A, just in terms of what next. We're going to be doing the trial, which is going to enroll 60 dyads and randomize them to either get the supporter-only intervention, the dyadic intervention, or assessment-only control. I just got scores from an R01 that I submitted to NIMH to test this intervention. It is not, they're not good scores, but at least it was scored. That was, I was surprised by that. And so I'm hoping to get kind of more funding to do this on a broader scale once we've gotten this pilot data from this Department of Justice grant. So I am excited, kind of looking forward to that. And just to close, I want to just reflect on this concept of giving psychology away, which I'm sure all of you have heard before from George A. Miller's presidential address in 1969. But I think, you know, really thinking, for me, my value in approaching my work is thinking about how I can give this away and put myself out of a job and make myself obsolete. And I think, you know, this has been something that we've been called upon to do for more than 50 years now. And I don't think that we're fully successful in this, even with all the innovations we have. And so I wanted to reflect on this because I think this is a concept that many of you also value. So with that, I thank you so much for your attention. If you have questions about any of this, feel free to reach out to me. But I would love to kind of get your thoughts and reactions and just sort of discuss this. So I will stop there.
Thanks, Emily. I'll just start. So I was curious, to what extent does your I mean, obviously it's a little different sort of way of getting at it. How does your intervention compare to what Katie Edwards and Sarah Ullman just did?
Yeah, so I was on that project as well.
Oh, okay. Well, then you could tell me all. Then you definitely know.
Yes. So that is supporting survivors and selves, SSS they call it, which is I would call it maybe primary or secondary prevention. So it's basically training undergraduates, regardless of whether, without an identified survivor in mind, just sort of training them in these general concepts. And some of the topics are very overlapping. The intervention had mixed and inconsistent effects in the pilot trial. And I think part of that is that it's hard to really think about how to use these skills without an identified survivor in mind and like an immediate opportunity to use them. The other challenge with that trial is that because there wasn't an identified survivor, it was really hard to collect outcome data for the survivors. And Katie had this brilliant kind of survivor, the supporter would refer survivors if somebody disclosed to them after they got the intervention, but it didn't end up getting many survivors and the data had some question marks. So I think this will clarify whether it being tied to an event that has just happened, so this would be within a few weeks after an assault happening, and actually being able to more directly measure results in survivors, whether this could have the same sort of benefit.
Yeah, I agree. I mean, it's a great idea, but this is something you may need to use in the next however many months, or you might not. Like, are you going to be able to retain that information if you don't get to practice it right away of interacting with a particular survivor that you care about?
Exactly. And I think there's a bit of a maybe, I don't know if it'd be a ceiling or a floor effect here, but just that the people that are presenting, the people that are presenting to get trained in this probably already are coming with a lot of empathy for survivors and a lot of motivation to help. And so it's not the person in survivors' lives who means well, but maybe doesn't know quite what to do and wouldn't have thought to do this without a survivor inviting them to do it. So hopefully that gets some movement too.
Yeah, I think that's a great point.
Chip?
Yeah, hi. So I obviously love this stuff. I mean, this is exactly where I think we need to go. I love this last slide, give psychology away. I think it's awesome. My fear with the GRIP program has been, and I wonder what you think about this, is the issues related to the dynamics of the relationships in which we're trying to step into, and the potential pitfalls of that. You know, I mean, I understand the low frequency CBT principles and what we're trying to give people, and they can learn these things. Any thoughts about those issues more generally, I guess?
Yeah, and Joe, feel free to chime in here as well, because we've talked a ton about this and we've really gone back and forth in terms of helping survivors select supporters that they're going to invite to this. That, you know, I think that my feeling is that this will work best for people that are well-intended and don't know what to do, and probably is not the thing for the jerk that thinks that this was their fault and that they have long-standing, really entrenched relationship conflicts. That's probably something that needs a more tailored and intensive intervention. Although, you know, I think the dilemma of that is that then, you know, we're probably missing some people that could really benefit from some intervention. But I just feel like it would need to be different, because a lot of the content around social reaction sort of gives supporters the benefit of the doubt and kind of tries to take their perspective on why they might react in unhelpful ways. And when people are being actively, you know, jerks, that it might just be harder to get that kind of change in a brief intervention.
That's a really interesting problem in my opinion that we started to think about in the intervention that I'm working on, which is helping people have a barometer when they engage in sort of vulnerable disclosure and work with their social network and especially their partners on their reactions, is like helping people sift through what is a worthy relationship that's healthy and what's one that's going to be sort of that maybe even needs to end.
Right. Well, and
yeah,
and Andrew and I talked about this piece yesterday, because this is a component of my app. But part of it is that not all people are the right people to disclose to. Like, not all disclosure is helpful disclosure. Trying to emotionally process with somebody that's just going to be a jerk to you every time you do it is probably going to cause more harm than good. And that's what, you know, Heather's data shows, and what the meta-analysis of social reactions seems to show, that, you know, it's more likely to cause harm than it is to help. And so I think we do want to help survivors think carefully about who they're choosing to engage with about these things, and selectively engage, even if they keep those relationships but benefit from them in other ways, not taxing a relationship more than it can accommodate. And since I know we have a few minutes left, I see Mimi's hand up as well. Did you have a question?
I do, yeah. I was actually just reading your meta-analysis before this, so it's very fresh. But I'm kind of wondering, because I've lately been reading a lot of qualitative work around social reactions, and it does seem like there's this issue of, you know, the perceived versus received kind of dichotomy that we break it up into, and especially for things like maybe things that might fall under something like an egocentric reaction. So like getting angry at the perpetrator. I think, you know, some survivors might actually find that rather helpful and validating, and being like, well, you know, I'm allowed to be angry. Like, yes, this was a big deal because this person is getting so angry about it. So just things like that, where perceptions, you know, of that kind of negative reaction do seem to differ. I'm just wondering, like, how in application, when you're trying to help people be the best supports that they can be, like how you deal with that, if you deal with that at all, or if that's something that you talk about in the content.
Yeah, that's an excellent question. And the way that we deal with that, I think this intervention is actually really well set up to accommodate that, because every time a piece of information is presented, it's presented as, this is one possible way to think about this and approach this, which is part of it addressing cultural inclusivity too, not assuming that this is the only way or the right way to do this, but then saying, okay, well, how does this apply to you and your relationships? How does this feel to you? And then gives the survivor and supporter a chance to have an open conversation about that. It's a little trickier when the survivor isn't there, but the supporter can still spend some time reflecting on, you know, how would you know if this was something that the survivor was appreciating or not appreciating? You know, is this something, in the supporter only one, the supporter is taught the information, and then they're given that guidebook that I showed you to basically set a time with the survivor to go over all the content. So there will be those opportunities to ask, you know, is this true for you? Or for the survivor to kind of course correct if that's not the case. Because I definitely agree, especially for egocentric ones. I think that's a great example of that. There's really mixed perceptions of whether or not they're helpful.
Just a quick comment on this. So, you know, we tried in a way to head some of this off at the curve by really encouraging people to select with careful forethought the confidant, right? In that way, you know, cut out some of it. It becomes harder in, Emily, your really wonderful extension of this to sexual assault, because, you know, they may likely have supporters with them, and these supporters may be in relationships with them, and it's complex. But I want to just comment on something about all of this, because I think it's tremendous. And your work, Emily, has breathed life into this. You know, the brief dieting intervention is identified by STSS as a promising early intervention, but really nobody's followed up on it in 20 years. And I will say to members of the Institute, if you want to do research with this kind of intervention or similar things, I think it would be immensely fundable. This is the one, probably the most brief early intervention ever to prevent PTSD. And, you know, it's a low intensity thing. So we're not micromanaging a lot of the complexity of disclosure. So I think you know, this institute has a whole lot of in-depth experience in social supports. But I want to just mention it. There's I think implicit in this are paradigmatic changes for clinical psychology and some great improvements in research. One is, social support. We know it's the biggest predictor, but there's hardly any interventions out there that have actually focused on tweaking or changing social support. So disclosure and emotional processing is important, but there's a lot of things there. It's also natural recovery. Natural recovery is being talked about for 50 years. So great that, Emily, you're thinking in these terms, but it's never been studied and it's never been harnessed very much. I'm using never in an extreme sense. So that's important. The big ticket item to me, the big ones, are the concept of building interventions for groups of people, for dyads or small groups or families, because trauma affects and travels with people. And I love your slide, Emily, of putting the needles at all the levels, because these people we train are going to be interacting with their friends and family for years. They're going to have hundreds of intervention events. And that's a game changer. And it's silly to focus on an individual when a lot of the variance in recovery is probably in the social context of recovery. And then the final thing is, I realized recently, psychology has never really tried to teach people to help other people. There obviously are exceptions to that, but I'll put it to you on a broad level. We could do enormous things by teaching people to intervene with the friends and family and the people around them.
It's such a careful enterprise in my experience talking about these things in the world of PTSD, because of how fixed we are around some ideas. Not in this institute, but in the larger landscape. And maybe that's something that doesn't matter, and maybe it does. But when we start talking about giving psychology away, that's complicated.
I do think that's changing to some degree. And I think the time is ripe right now for this kind of thing. And I want to thank Emily for her presentation today. Absolutely. And it's really great. This is such a fun group to do this with. And I'll leave you guys with a thought that I think we have to think beyond just the social context of people and think about how do we infuse sort of certified peer people who could be a support system for these individuals who are out there working. So it's not always funneling back to a clinical psychologist, but in some sense layers. So I think we have technology, and I think we have layers of certification that we could do for people in the community that could be a champion for a program, for example, a champion for GRIT, a champion for sexual assault survivors, so that there's somebody these people can go to and get additional support when they struggle. Because we all know that coaching in that context, helping people when they get stuck, can be extremely helpful. So I just think we can nuance this a little bit more even. So anyway, my 2 cents, but we could talk for hours. I think we're up to the hour though. This is only to 1, right, Brooks?
Yep.
Okay. So I'll let you guys all chat away, man, if you want. I think it's a great thing. Thank you, Emily. I appreciate that. And I'll sign off for now.
Thank you. I have to run as well, but feel free to email me if you have any questions or thoughts.
Thank you so much, Emily.
Thanks.
Thank you.
Excellent job.